I am Durga Sigal. I'm a consultant pediatrician from Queens. We started allergy teaching a month ago. So we meant to do overview of pediatric allergy and milk allergy a month ago, but we overrun of time. So we could not finish cow's milk allergy on that day. So I'm doing the second part of the teaching today. I would take too long, probably will take 30 to 40 minutes to finish the session. You could ask me a question. Probably it will be better if you ask me at the end of the presentation. Either you can put your message on the chat box and I'll go through the chat box at the end, or you can ask me a question directly. Over the next 30 to 40 minutes, I'll be talking about diagnosis and management of milk allergy. I will go through a little bit over the milk alternatives. We also talk about milk ladder. And then I will finish up with some of allergy phenotype, especially associated with the milk allergy, with some case studies. Just to begin with, milk allergy, as you know, with all allergy is a reproducible and immunological reaction. Just need to move this a little bit. In terms of milk allergy, it is induced by the cow's milk protein, but there should be two key features for this. It should be reproducible. Every time you expose the milk protein, child should have the same signs and symptoms, and it is usually immunologically mediated. As with other allergy, milk allergy are two types. One is IgE mediated. In this case, the children are sensitized, and when you do the allergy testing, you do the positive test result. There's another type, which is non-IgE mediated, where you don't get IgE in the body, but you get the allergic reactions. And non-IgE type of milk allergy is a bit difficult to diagnose. It mainly based on the history. The prevalence of milk allergy is between 2 and 5%. It also depends upon different studies and different population. In some population, it could be around 1.5%. In some population, you might see the 7 or 8%, but generally between 2 and 5% in the first year of life. Milk allergy usually is present in the first 6 months of life, typically when the child is exposed to the milk protein for the first time or subsequent occasion, they start to show signs and symptoms of milk allergy. It may present a bit later in life. It even present in adult. Those who present with milk allergy and later in the life usually have a severe type of symptoms. The prevalence of milk allergy in adult population around 0.5%, and this is usually more severe than mostly we see in the pediatric population. How do these children present? You have seen lots of these children in your primary care. It also depends upon what type of milk allergy it is, whether it is IgE mediated or non-IgE mediated. So I'll go separately on the symptoms. IgE mediated are usually immediate onset, and you do get signs and symptoms within first 2 hours, usually within minutes or within first 30 minutes, or it can happen within first 2 hours. And we usually get two symptoms. One is the skin involvement, which in the form of pruritus, bit of rash, urticaria, and angioedema. And after that, there could be system involvement, either GI, respiratory, or cardiovascular system. In GI symptoms, there could be abdominal pain, vomiting, or diarrhea. In respiratory symptoms, it could be cough, difficulty in breathing, or wheeze. In cardiovascular system, blood pressure may drop down, and which leads to drowsiness, pallor, or even collapse. If there is skin involvement or other system involvement, then it is classified as a severe type of allergic reaction or anaphylaxis. So typically, what do we usually see within anaphylaxis? Child is exposed to the food protein. It could be milk or any other food protein, and they have a bit of a skin reaction like urticaria, angioedema, and then we present with other systemic feature. It could be cough, wheeze, or even drowsiness or collapse. So the skin involvement plus other symptoms is severe type of reaction / anaphylaxis. On the other hand, delayed type of reaction or non-IgE type of reaction, this usually does not present immediately after exposure to the food protein. It may take hours or even days. Within 72 hours, symptoms may present. And usually non-IgE type of allergy present either with skin symptoms or GI symptoms. In terms of GI symptoms, we have seen the baby with a non-IgE type of milk allergy. One of the commonest features will be they are unsettled due to abdominal pain. They're crying or unsettled baby. They could have diarrhea, vomiting, or constipation. They may present in the blood in the mucus with the procolitis, bloating, or they may refuse the food if the food is continued to offer these children who have non-IgE type of allergy. Apart from gastrointestinal symptoms, they also present with the skin manifestation. The commonest skin manifestation is a flare of eczema, especially in the younger children. The food protein may be causing the eczema flare up, and if the children are giving the food protein that are allergic to, their eczema will flare up, but it may not happen immediately, so it can happen after a few hours or even after days. So this is the summary which I just talked about. IgE, non-IgE, it can apply with any food, not only with the milk allergy. IgE type of symptoms are present in the first 2 hours, and delayed can be hours and days. IgE type of skin symptoms, particularly edema, or if your reaction is severe, then with the systemic involvement. But non-IgE type symptoms are eczema, reflux, constipation, and diarrhea. IgE allergy is a bit easy to diagnose because we have got validated test. We can do skin prick testing a specific IgE, but in non-IgE type of reaction is based on the history. Thus, it is harder to diagnose. How do you diagnose milk allergy? Most of the time, it's a history. So there is usually typical type of signs and symptoms as we just discussed in IgE and non-IgE type of allergy. Usually IgE type of allergy is easy because the child is consuming milk protein and they immediately after they start with typical symptoms. But non-IgE type of allergy is not always straightforward. And once you get the convincing history, then you have a fair bit of idea, and you can tell that whether the child has allergy or not, and that is also helps you to assess the pretest probability when you order the allergy testing. There are mainly two types of allergy testing, as you know. One is the skin prick testing, another is a serum specific IgE. In primary care, probably you won't have a facility to the skin prick testing, and most of the time we rely on the specific IgE. The skin prick testing is easy to carry out, and you can carry out multiple food at the same time, and the child usually tolerate well. On the other hand, but you need to have a facility. You need to have someone who can do the skin prick testing on your setting. On the other hand, specific IgE, we need to get the blood sample, and it usually takes time to get the result. Usually 1 to 2 weeks to get the specific IgE result. If there's a strong history of IgE type of allergy, then probably it's a sensible thing to request the IgE to that particular food. But the one thing in allergy, the allergy testing usually don't tell you whether the child is allergic or not. We do the allergy testing just to confirm our diagnosis, and most of the time the history will give you the clue whether the child has got allergy or not. In many occasions, the allergy testing, whether it's skin prick testing or a specific IgE, can be misleading. This testing can pick up the sensitization. The child may not be allergic to the food protein, but child can be sensitized. Especially children with the eczema, they tend to be sensitized. And the children with the eczema, if you do the multiple food testing, they can be positive with the food, but they are not necessarily allergic to. So when you do the allergy testing, we always have to keep in the context of the history. If there's no history of an allergy, probably it's not a good idea to do the allergy testing, because you may get the sensitization and it may be difficult to explain to the parents. But if there's a clear history of allergy, that we to confirm that, we tend to request specific IgE or skin prick testing. The other thing we could do is oral food challenge. We can do two-way open or double-blind placebo-controlled food challenge, which is the gold standard, but this is usually done in the research basis. We don't do it in clinical practice just to diagnose the food challenge. We usually do the food challenge to see whether the child has grown out of the food allergy or child has developed tolerance to that particular food. When you do the allergy testing, the skin prick testing is a 3 millimeter or more is classified as a positive result. Similarly, when we do the specific IgE 0.35 or above is regarded as a positive result. But as I mentioned earlier, it is very important that always we put the allergy testing result in the context of the history. We never interpret the allergy testing result alone without the history. So let's talk about the management. How do you manage? Once we confirm the diagnosis, the child has got the milk allergy, whether it's an IgE type of non-IgE type of milk allergy. The first thing to do is the dairy avoidance. If the child is allergic to milk protein, then we need to avoid the dairy product. But dairy products are very important in the child diet. It's a rich source for calcium. And when you take the dairy out from the child diet, we need to think about the suitable alternative formula. So breast milk is suitable for the most of the cow's milk protein allergy. If the mother is breastfeeding and the child is still showing signs of symptoms of milk allergy, then the simple thing to do is to ask the mother to take the dairy out of her diet. But doing so, we need to be very careful because the mother has, the dairy products are important source of nutrition for the mothers, especially for the calcium. So if we advise mother to take the dairy out from her diet, we should advise mother to take the calcium and vitamin D supplement. The current advice is mothers should be taking 1 gram of calcium and 10 microgram of vitamin D, especially if she's lactating. But the amount of dairy product in the mother milk is very minimal. So one of the studies shows that only 0.5% children who have a milk allergy are reacting with the breast milk. That means 1 in 200 children. So we should be always careful when we advise mother to stop dairy product. We should be sure that it is causing the problem. And the amount of milk produced in the mother's milk is very minimal. If the child is bottle feeding, then we need to find the suitable milk alternative for that child. And the suitable milk alternative could be hypoallergenic formula. There are 2 types of hypoallergenic formula we currently use. One is extensively hydrolyzed formula, and the second is amino acid based formula. In extensively hydrolyzed formula, there is a milk protein, but is hydrolyzed, so it's broken down in small pieces. Even is broken down finely so that it's not that allergy, but it contains the cow's milk protein in itself. So the first choice is extensively hydrolyzed formula. In certain circumstances, then we prescribe amino acid based formula. The indication would be if there's anaphylaxis to cow's milk protein, or if the child is already in extensively hydrolyzed formula, but the child is reacting to extensively hydrolyzed formula, then we will go up in the amino acid based formula. If there's a concern about growth, if the child is getting enough weight, or if there is a colitis, signs of colitis, and as a result of child not absorbing, in that case, we prescribe amino acid based formula. If the history of severe symptoms, for example, is eczema, severe eczema, or there is history of multiple food allergy, that could be one indication for amino acid based formula. Or if the mother is a breastfed infant who react with the mother milk, then that could be one of the indication of amino acid based formula, but not always. The bottom line is first choice is extensively hydrolyzed formula, and if this extensively hydrolyzed formula is not working, or there is history of anaphylaxis or other indication, then we will go to amino acid based formula. So there is a soya based formula. I will talk a little bit in detail with other milk alternative. So soya-based formula are not suitable for children with less than 6 months of age because it contains phytoestrogen, and phytoestrogen can affect the child's reproductive health. So we don't advise to give soya less than 6 months of children. And the other problem with the soya-based formula is the cross-reactivity with the milk protein. About 10 to 15% children with the IgE mediated, or around almost 50% children with a non-IgE mediated allergy can react with the soya-based formula. So the children with the milk allergy may not always tolerate the soya-based formula, but we can try. The other formula we discussed earlier, this extensively hydrolyzed formula and amino acid-based formula, they taste not very good. The palatability is a problem. If you have tested this hydrolyzed formula, they don't taste very well. What tend to happen, sometimes we give the extensively hydrolyzed formula or amino acid-based formula, and parents come back to us saying the child is not accepting the formula. And you don't blame them because they don't taste very well. So sometimes it may need multiple attempts. We may have to offer the child multiple times before they accept this formula. On the other hand, soya-based formula are more palatable than the extensively hydrolyzed based formula and amino acid-based formula. So it is a bit better from that perspective. What about other mammalian milk? So there are other milk products available in the supermarket, for example, goat milk, buffalo milk. But these are the same mammalian milk and they contain the milk protein. So these are not recommended to the child with milk protein allergy. So we don't advise parents to take this formula. And one of the important aspects is really important. If the child has a milk allergy and we're taking the milk out from the dairy, out from their diet, I usually make a referral to dietitian because it is very important that child is suitable alternative formula, child is getting enough calcium and vitamin, and child is growing appropriately. So the dietitian can go through about the nutrition and how much child is getting and growth of the child as well. So it is very crucial that we refer these children to the dietitian, and I'm sure that you will have access to the community dietitian for these children. In my practice, I always involve dietitian if the child has a milk allergy. So hypoallergenic formula. So these are the few pictures I got from internet. The first row you can see these are the extensively hydrolyzed formula: Optamil, Similac, Elementum, SMA, Altera, and Nutramazine. And the second line are amino acid-based formula. Extensively hydrolyzed formula contain milk protein, but they are finely broken down. These milk products are either casein or whey based. As you know that milk protein has two types of protein, either casein or whey. I think Optamil and SMA Ultra, they are whey based, and Similac, Elementum, and Nutramazine are casein based formula. Similac, Elementum, and Nutramazine contain lactose as well. These are the similar product, but they may have a slightly different composition of slightly different nutritional value. On the other hand, amino acid based formula, they don't contain milk protein, and they only contain amino acid. So these are suitable for any kind of milk allergy children. The difference between the extensively hydrolyzed formula and the amino acid based formula, one of the main difference is amino acid based formula are more expensive. I think the price is double compared to the extensively hydrolyzed formula. So all the products are similar. So I think in our trust we prescribe Similac, Elementum. So you may have a different guidelines from CCG because they have a contract. So just follow your local CCG guidelines in terms of prescribing extensively hydrolyzed amino acid based formula. But one of the things I've noticed that sometimes the children may not like one particular product, and if you change the different product, they might tolerate that one. So sometimes if the parents come with the history the child is not accepting or not tolerating, then sometimes I change the product first and see whether they can tolerate. This is the allergy action plan. You may have come across of this before. This is from the BSACI website. It's a British Society of Allergy and Clinical Immunology. Any children, not only with a milk allergy, with any allergy, we should give allergy action plan to the parents. You can get this allergy action plan if you type in Google BSACI allergy action plan, you'll get this. There are two action plan on the screen you can see. On the left-hand side is with the allergy action plan with the EpiPen or adrenaline auto-injector. On the right-hand side, allergy action plan without adrenaline auto-injector. So what you can do is on the top of the allergy action plan, you can write down what the child is allergic to. It could be cow's milk, egg, peanut, or any food, and then you put a name, date of birth, and it says if there's a mild to moderate reaction, you're advised to give antihistamine, cetirizine. And if the reaction is severe, then it advised to give EpiPen, or if there's anaphylaxis. And this allergy action plan also explains how to give EpiPen. So it's very useful, especially children who goes to nursery or to the childminder. They know what to do if there's allergic reaction. On the right hand side, is the allergy action plan without adrenaline auto-injector or EpiPen. If there is history of anaphylaxis, then we should prescribe adrenaline auto-injector. Currently, there are two products available in the market, is EpiPen and Jext. They come in the two different strengths, 150 microgram and 300 microgram. We don't have any product with the 500 microgram at the moment. There used to be a product called Amirad, which has been taken out of the market at the moment. Hopefully that will come in the market soon. But when you prescribe EpiPen, if there is a history of anaphylaxis with the milk allergy or any other food allergy, please also provide the training to the parents. Our responsibility does not end just prescribing the EpiPen, because parents need to know how to use it. If there's anaphylaxis and parents do not know how to use it, there's no point. So parents must be taught how to use EpiPen. You can use the dummy EpiPen to train them in a clinic, and then direct to the different video. There are lots of videos available in YouTube or Anaphylaxis UK website where parents can go through and have a look on the video. So we diagnose the child, we put them on suitable milk alternative, and then at some point we need to plan about dairy reintroduction. When is the best time? In non-IG type of reaction, we tend to reintroduce dairy product around year of age, around 1 year of age. 9 to 12 months is the suitable age, but some people also argue that 6 months, once the child is 6 months on the specialized formula, then we think about introducing the dairy product. When we introduce the dairy product, we always start with the baked product first. And the reason for that, when we cook food, especially with a high temperature, the structure of the protein changes and it becomes less allergenic. One of the way we do is introducing with the milk ladder. I'll discuss milk ladder in the next presentation. We advise to go from the baked product or well-cooked product and gradually go up on the fresh product. If the child has a non-IG type of milk allergy, the dairy can be introduced at home. If there's a mild symptoms of, or if there's no reaction in the last 6 months, or if there's a significant reduction or skin prick testing or a specific IG level, home introduction can be carried out. We tend to do hospital food challenge if there's a history of severe reaction in the past. For example, anaphylaxis, child reacted to the trace amount of the food, or the child has a multiple food allergy, or the child has asthma. Or the other important factor is the parental confidence. If the parents feel that they can do it at home, they can recognize the allergic reaction and they know how to manage it, then it can be done at home. But even with the mild symptoms, if the parental understanding is poor and the parents can't manage any allergic reaction at home, that would be an indication to do the home introduction. But having said that, most of the non-IG type of allergy, milk allergy, the milk introduction can be done at home. This is milk ladder. I'm sure you are familiar with the milk ladder and you must have used it many times in primary care. There are two milk ladder. You can choose either. The right-hand side has the multiple steps, 12 steps, and the left-hand side has the 6 steps. So you can choose either. You can go slowly or you can go a bit faster with the left hand. Again, you start with the baked product and you gradually go up on the fresh product. So there's no hard and fast rule how long child should stay on the one step. For example, if we start with the milk ladder, I'm giving the example from the left side of the milk ladder, and it's step 1. We started milk ladder with the biscuits, and then what is the whole idea of introducing milk ladder is we want to develop tolerance on the child. So you suggested parents to give biscuits for a few weeks. I usually advise parents to give it for a few weeks, but there's no hard and fast rule. And then if the child is tolerating, go to next step, for example, morphine, and stay on the same level for the next few weeks, and the child is tolerating, keep going up. What can happen in the usually if child is tolerating the dairy product from the one step, for example, if the child is tolerating biscuit, but when parents give morphine, the child may react. So in that case, the advice will be to continue giving biscuit. What we want to do is we want the child to develop tolerance. If the parents stop giving biscuits, and the child might lose that tolerance. So continue giving biscuit again, which child is tolerated before, and after a few weeks, challenge the child with the one step up, for example, morphine here. And the same thing applies when they continue to go up on the milk ladder. So these are some of the dairy alternatives which is available in the market. We talked about the soya product earlier, not for the less than 6 months for the soya product. The one important thing about the dairy alternative, they are not as good as milk in terms of nutritional value. So we usually don't advise to give this dairy alternative in less than 1 year of age as a main drink, but they can be useful for cooking or just to put on the cereals. They contain different amount of protein and the vitamin in this product based on the manufacturer. So we have to be careful when we suggest the parents to give this milk alternative. One of the caveat is that if the child has the nut allergy, you can't give the nut-based formula. For example, almond, hazelnut, or coconut milk. Rice-based formula are not recommended to children less than 4.5 years of age because of arsenic content on the rice. Whenever we advise the parents to take this dairy alternative, I always suggested them to take a formula which is fortified. That means that contain calcium and other vitamin supplements. So what is the prognosis or the outcome of the milk allergy? So most of the children with a milk allergy grow out of it by the time they start school. So around almost 80% children, or in some of the studies, it says around 70%, 70 to 80% children grow out of milk allergy by the time they start school. In some children, milk allergy can persist, and most of the times it will be IgE type of allergy, or children who has got the multiple food allergies, especially the egg and nut allergy, and the children who have other allergic comorbidity, for example, asthma, allergic rhinitis, are likely to be persist more than the children with a single milk allergy. So who needs referral to secondary or tertiary care? I think most of the non-IG type of milk allergy can be managed in the primary care. So what these children needs is to identify their symptoms, put them on the suitable milk alternative formula, and introduce dairy product around 1 year of age. For these children, it is important that we involve the dietitian early, so the dietitian can monitor the nutritional value of the dairy substitute they are having, and they're growing appropriately. So with the diagnosis and putting them appropriate hypoallergenic formula and introduction of dairy product around 1 year of age with the help of milk ladder will be the approach for the non-IG type of allergy. But there are certain circumstances the referral to the secondary center is advisable. That would be any IG type of allergy. If there's a diagnostic uncertainty, is not sure whether it's a milk allergy or something going on. And the other thing is the child not gaining weight. There could be something else going on as well. So in this case, the children needs to be referred. If the child has ongoing symptoms, despite putting the child in hypoallergenic formula, then that will be another indication. Child with severe eczema, multiple food allergy. And the other entity is a food protein-induced enterocolitis. I will talk about this a little bit detail in the next slide. This is the new entity we are seeing with the food allergy. I want to touch base on lactose intolerance. The reason I want to bring this up because the signs and symptoms of lactose intolerance overlap with the non-IG type of milk allergy. As you know, lactose is a disaccharide, and our intestinal border epithelium produces enzyme called lactase, and lactase helps to break down lactose into glucose and galactose, which is easily digestible. If there is a deficiency of lactase enzyme, then the child may present with the signs and symptoms of lactose intolerance. So that could be usually abdominal bloating, excessive flatulence, and explosive diarrhea. So lactose intolerance, there are three types: the primary, secondary, and congenital. Primary lactose intolerance, which is usually the natural history of lactase production. What happened? The level of lactase enzyme is highest in the first few months of life, and gradually the lactase level drops down. So that lactase enzyme level drops down. That also depends upon ethnicity, and that is also determined by the genetically, but it gradually reduces down. It doesn't stop abruptly, but it gradually reduces. So that's why we don't see lactose intolerance that often in the young children. It's usually in the older children or in the adult. We see the primary lactose intolerance. The other type of lactose intolerance we do see in little older children is the secondary type of lactose intolerance. So what happens if due to infection or some other reason, there's an insult in the intestinal border epithelium, and that is not producing enough lactase enzyme, then we do see the secondary lactose intolerance. So if the child has infected diarrhea, then there could be some damage in the border epithelium, and that may not produce a lactose temporarily. But once the child is recovered after a few weeks, and the same amount of lactase is produced, and then the child would not have any problem. So we do see the temporary lactose intolerance after the gastroenteritis. And the other time we do see secondary lactose intolerance is the child with the inflammatory bowel disease, for example, Crohn's disease, or if there's a celiac disease. In that case, you also do see the secondary lactose intolerance. The other type of lactose intolerance is a congenital lactose intolerance, when the individual does not produce any lactase. It is very rare condition, and we usually don't see. It is usually common in the North European and Russian population, but I haven't seen any congenital lactose intolerance. As I mentioned earlier, the symptoms tend to overlap. But what I want to highlight is lactose intolerance is very uncommon in the young baby. So it's quite unlikely to be lactose intolerance. But if you're worried, usually the diagnosis is exclusion of lactose and then reintroduction. The lactose-free milk are easily available. We can put the child on the lactose-free milk for 2 weeks, and if there is improvement in symptoms, then reintroduce lactose after that and see what happens. We don't do any investigation for the lactose intolerance. I think there is some investigation, for example, hydrogen breath test and some blood tests. I don't know whether it is done in the adult population, but we don't do in the pediatric population, certainly not in our trust, and I'm not aware of any other trust which offer. If it's lactose intolerance is confirmed, then the management report or partial exclusion of lactose from the diet. So I want to bring up this. It's a very common question. You might have asked it before. You might be facing this question in future, because there are lots of children who are allergic, and the parents might come back to you when they have a younger siblings. For example, if the older sibling has a milk allergy, and they have the family has a new baby. So what we do with the younger children? Do you prescribe them hypoallergenic formula? It applies with any other food allergy. What is the evidence? Is suggested that if the sibling has got the food allergy, it doesn't increase the risk of food allergy in the younger infant. So the advice is we should not do extra thing. We should manage the younger sibling as we manage with the general population, but the parents should be aware of any sign of allergic reactions, and I think they need to be more careful. Not in milk, but what tend to happen with other food, especially for the egg and peanut, if the sibling is allergic, the parents may tend to introduce this allergenic food in this younger sibling diet later, and that itself can increase the risk of allergy. As you know, that the current evidence suggests that if you introduce allergenic food early in the diet, the chances of being allergic is less. So the usual advice is, this is advice from BSACI. If there's a siblings is allergic to any food in the family, they can introduce other food in the younger sibling as they do normally, but they should take the precaution, identify the allergic reaction, and they need to be careful with the other child who is already allergic to that particular food in the family. So they need to keep the other child safe from the allergic reaction or exposure to that particular food protein. So I'm going to go through the two case studies. It's related to cow's milk protein. So the first one is a 3-month-old child, exclusively breastfed, had noted blood in the stool. Child is otherwise well, thriving. You send the stool sample, and the stool sample is negative for MCNS. So there's no bacteria, no Campylobacter or anything. So basically, well child, but the blood in the urine. So what is the diagnosis? So diagnosis is allergic proctocolitis or allergic colitis. We do see this. This is not very uncommon problem. We do see quite a lot. It is usually in the infant is 2 to 8 weeks of age. They are either breastfed or bottle fed. They are healthy. There is a blood in the stool. They are gaining weight. If you investigate these children, they are usually the simply testing IgE is negative. The most of the common food is milk, but it can happen in the other food as well. How do you manage the children? Is if the child is present with the allergic proctocolitis secondary to milk protein, if the child is breastfed, the mother needs to take the dairy out of her diet, and we give the usual advice. The mother needs to take the calcium and the vitamin D supplement. And if the child is bottle fed, then we tend to give extensively hydrolyzed formula or amino acid-based formula. And these children do well, and the symptoms gets better. The blood in the stool gets better after taking the milk protein completely out from their diet in 72 hours. And these children are managed as we manage with the non-IgE type of allergy. We usually introduce dairy product in this children diet around 1 year of age. So these are usually managed as in line with the non-IgE type of allergy. So basically take the milk out from the dairy out from the diet, monitor growth, and introduce dairy product around 1 year of age, and they usually do well. The second scenario is a 5-month-old child, exclusively breastfed, but was given cow's milk for the first time around 5 months of age, and immediately child developed profuse vomiting, pallor, drowsiness, and capillary refill time 4 seconds. That means child is in shock, dehydrated. Child was rushed to the hospital, given IV fluids and IV antibiotics. Started on antibiotics. The bloods and all the septic skin was negative, and child made a rapid recovery within the next 12 hours once the child was in IV fluids. You may or may not be come across of this problem. So this is F5. It's called food protein induced enterocolitis. It can happen with the different food. Milk is one of the common food. This is non-IgE type of allergy. And we don't know, the pathophysiology is not well understood. It's like non-IgE type of allergy. Usually what happens, child is exposed with the food protein for the first time or second time, and the hallmark of symptoms is they usually present with the profuse vomiting after 1 to 4 hours. Due to the repetitive vomiting, they lose lots of fluids and present as a shock and dehydrated. And they often treated with the sepsis, and they may have a diarrhea. They mainly present with the profuse vomiting, but they may present with the diarrhea after a few hours, and the symptoms typically resolve within 12 to 24 hours. Milk is the common food protein, but it can happen with any other food. Currently, I have a child who presented a few months ago with F5 with banana. So he was given banana for the first time. He came to us at treated as a severe sepsis and made a rapid recovery. After a couple of weeks, the child was given banana again and exactly had the same symptoms. So that was a food protein-induced enterocolitis. Acute management is managed with the antibiotic and oral with the IV fluids. If the symptoms are moderate, mild symptoms, they are given oral fluid, but the severe symptoms, then we tend to give IV fluids, even they need a fluid bolus. And these children do not need EpiPen or anything. This is not IgE type of allergy. Those children who react, who have F5s, we should take the food protein out from their diet completely. Again, if the child presents with the F5s with the milk, they need a dietetic input and nutritional support to make sure they're getting enough nutrition. If the mother is breastfeeding and child is doing well on the breast milk, and when the child was given formula feed for the first time and presented with the F5s, mother can continue giving breastfeeding as she is before. So I'm just going to finish up with some of the slides. You can see the important website. One of the where you can get lots of information about allergy management. One of the website is BSACI. BSACI stands for British Society of Allergy and Clinical Immunology. It's for both adult and pediatrics, but there are lots of information and it produces lots of guidelines about the allergy. And one of the important things, you can use BSACI for the allergy action plan, which I showed you earlier. There's another website called Itchy Sneezy Wheezy. This is from the St. Mary's allergy team, especially if you're prescribing EpiPen or nasal spray, or how to use inhaler. So there are very useful videos in Itchy Sneezy website. So you can direct to the family to go home and have a look at these videos. In Anaphylaxis UK, there are useful video how to use EpiPen. Similar in Asthma UK, you can get useful video how to use inhaler or asthma action plan. So these are some of the useful resources. In your primary care also, there may be other resources for the allergy. So that's it from me. We're going to 45 minutes, more than expected. I'll be happy to take any questions. I'm just going to go to the chat box now. I can't see any questions there, but if you got any questions, please feel free to type here or ask me directly. Silence. Amy, are you still there?
I am here. Does anyone have any questions before we get going? We have one from Susie.
Let me have a look. Let's see. How common is eczema in under 3 months old? Should you be considering cow's protein allergy? Yes, it's very common. I think eczema many times the eczema started early in the life, from the first few days of life. You should consider cow's milk protein allergy in eczema, but not always. What tends to happen in the younger children is the eczema is not well controlled or difficult to control, then the food protein may be the culprit for the eczema, especially milk and egg. But if it is a mild eczema, and there's no clear history of eczema flare-up, then not. So what usually tend to happen if the milk is causing the problem with the eczema, especially in non-IG type of allergy, what parents give the history that the child is exposed to the milk protein and then the child eczema flare up. There's a typical history, but if you are not sure, what we tend to do it, if you think the milk protein is causing the eczema flare up, what then you could do it, you can take the milk out from the diet from around 6 weeks of time and see whether the eczema gets better. You take the milk out for the 6 weeks and the eczema got better, and then to confirm that diet, to confirm your impression, reintroduce milk to the child diet again. If the eczema gets flare up, then yes, the milk is causing the problem. So just to summarize, to answer, it could be, but not always. The one thing I really want to mention that is milk allergy is very overdiagnosed at the moment. What we can see is if the child has a vomiting, bit of diarrhea, bit of constipation, then the tendency is to change to the hypoallergenic formula. But these symptoms are very common in the babies. The baby can cry, baby can have a colic, the baby can have a reflux, that's they vomit, they can have a bit of constipation, and all the crying baby, all the reflux symptoms and all the constipation is not milk allergy. So we need to be careful before we label these children with a milk allergy and putting the hypoallergenic formula. There's a big implication when you advise the mother to take the dairy out from her diet, or when you put the child in the hypoallergenic formula. So we should consider very carefully before diagnosing these children and putting the other dairy substitute. The second question I got, how to make a diagnosis of a non-IgE allergy by exclusion of SPT and specific IgE. So as I mentioned earlier, it's not easy to diagnose non-IgE type of allergy. It's based on the history. With the typical history, if the child is reflux symptoms, a child is very unsettled, or there's a blood in the stool, or child is constipation. Once you rule out the other common causes of those things, so once you rule out if the child is vomiting, not due to the reflux, it's not due to cow's milk protein allergy. So if you rule out the other causes of those symptoms, then it could be non-IgE type of allergy. And in non-IgE type of allergy, you do not get the positive skin prick testing or specific IgE. These are negative. In some circumstances, you do get mixed picture with both IgE and non-IgE type of allergy, and in that case, you do get the mixed symptoms. And when you investigate this children, you do get the positive result. But it's purely non-IgE type of allergy. The allergy testing result is negative. There's one particular condition you may get the positive result, that is if the child is sensitized with this food protein. That usually happens with the eczema. If the child is eczema, those children may be sensitized with that particular food protein, and you do get the positive allergy testing, but child is not necessarily allergic to that food protein. There's another question I can see. What is the major difference between the cow's milk protein allergy and lactose intolerance in terms of diagnosis? I think, as I said before, lactose intolerance is not common in the young babies. As I said, is in the lactase enzyme level is higher in the first few months of life. So they usually don't have the lactose intolerance. Lactose deficiency is usually common in a bit of older children who have the infective diarrhea or other GI problem, for example, inflammatory bowel disease or celiac disease. I know it's not always straightforward because non-IgE type of symptoms and lactose intolerance symptoms overlap, but usually in the younger children, the lactose intolerance is not that common. So I won't put them lactose intolerance in very young babies unless there is other clear history of infection or illness. The other question is, does anti-allergics have any role to success in milk protein allergy? I'm not quite clear what you mean by anti-allergics.
Anti-allergic medication, in other words, yeah. Right.
Oh, so that means antihistamine.
Yeah,
is that right? Have I got your question right?
Yeah.
So antihistamines, we don't give antihistamine like cetirizine or pyridine, chlorpheniramine to prevent the allergy. So antihistamines are used to prevent the sign of symptoms of allergic reactions. So we don't, if the child has milk allergy, we don't put them in antihistamine. But what we tend to do is, if the child has IgE type of allergy, for the mild IgE type of allergy, we prescribe them antihistamine, usually the cetirizine. But not to prevent the milk allergy. It's only to prevent the sign of symptoms of allergy symptoms.
Thank you.
Any more?
Any more questions before we go, anyone? I believe that is all.
So in that case, we'll wrap up. I hope it was useful. You could get something from it. I think Tammy will send the presentation slides to you anyway. I'm happy to contact you if you got any questions. If you have a milk allergy, for example, simple milk allergy can be managed in the primary care with a non-IG type of, but if you're struggling or of IG type of allergy, feel free to refer to us, and we're happy